Well, good evening, everybody. Welcome to tonight's lecture. Vet Education is proud to present a free webinar on critical illness-related corticosteroid insufficiency. It's a pretty interesting condition that we're going to talk about tonight. It's lovely to see people logging in from all over the world. We've had just under 2,000 people register for this lecture, so thank you for being part of this huge online event that's actually being brought to you by an upcoming course that we have. It's called Nursing Care of the Critical Patient. It's a 4-week online course starting on the 31st of May 2021, so in about 10 days time. There's still plenty of time to register, but if you want to find out more about the course, it is a 4-week course that's been race approved, so that you can get race CPD points if you need them. We have live tutorials pretty much similar to the sort of tutorial that we'll have this evening that cover the weekly topics. There are also free practice protocols and checklists. As you can understand, with a critical care patient, there's lots and lots of things that we need to check on with these patients. So we're going to be producing disease management protocols, checklists, and so on, so that we can make the most of our interactions with the patient when we are nursing them when they're critically unwell. As well as that, we've got the latest reviews and information, so your course notes are 100% up to date with the latest in what is known in the literature as well. So we'll talk a little bit more about this course a bit later on this evening. There's also a bunch more stuff as well in the courses too. But let's get on with tonight's lecture, all about critical illness-related corticosteroid insufficiency. I'm Philip, your lecturer for this evening. I've been a critical care vet now for 23 years, postgraduate qualifications in emergency and critical care and medicine of dogs, and a published author in snake envenomation in Australia as well. For those of you who want to find out more about me, there's a little bit more on the Vet Education website as well. Let's get right into tonight's topic. What is critical illness-related corticosteroid insufficiency? Well, if you look up in most medical textbooks, you'll get a definition something like this. It's an insufficient cortisol response or an inadequate cortisol activity for the existing degree of critical illness. And that in itself tells you something about the disease, but it's not all that helpful. So let's have a look at a patient. Let's have a look at a real patient that had tick paralysis. He developed aspiration pneumonia as a result of reduced gag and swallow responses. He was in septic shock, and I'll tell you a bit more about him in a couple of slides' time. He was hypotensive despite fluid therapy, so he was in shock. We gave him intravenous fluid therapy and nothing really changed. His heart rate didn't change, his blood pressure didn't change that much. He was azotemic. He had evidence of poor tissue perfusion as well, so poor gut function, diarrhea, and so on. So this is the patient that we have. This could be mirrored by any number of patients that you might see in your practice, patients with pancreatitis or peritonitis, even parvovirus enteritis, big dog versus little dog bite injuries, dog versus cat bite injuries as well. You will see patients with similar types of severe systemic illness. So in this particular patient, he had symptoms of hypovolemia, such as weak pulses, dull mentation, pale mucous membranes. He had tachycardia. He also had signs of sepsis as well, some of which mirrored his symptoms of hypovolemia and the tachycardia and the weak pulses, but he was also pyrexic. He had evidence of aspiration pneumonia or purulent exudate. When we intubated this dog to begin his ventilation therapy, there was evidence of pus on the ET tube, and he also had clinical evidence of poor perfusion. His blood lactate on admission was 8.9 millimoles per liter. He also had elevated urea, creatinine, and phosphorus, so he had organ dysfunction resulting from the hypovolemia and systemic inflammation that took place in him. So what should we do for this particular patient? Please feel free at any time, if you wish to type in your suggestions, please just type them in the chat box there, and we'll pick those up if you've got any suggestions or questions throughout the lecture. So what are we going to do for this dog that's got septic shock? Well, we're going to obviously monitor him quite extensively. we already have we wanted to get a blood pressure reading from this particular dog. We might need to get blood gas analysis from this patient. We're going to need to monitor urine output here. We're going to put him on a ventilator. This is, the ventilator's out of shot there. And we're going to need to give him some oxygen therapy as well. Vasopressors, Janelle, thank you so much for that suggestion there too. So I think that's a brilliant idea, and we'll get to that just in a little bit. We did an ultrasound of this dog's lungs and found that there was evidence of these vertical lines here, these lung ultrasound lung rockets, or B lines, depending on which reference you use. And these are suggestive if you are putting an ultrasound probe on the chest wall between the ribs. This is suggestive of intrapulmonary fluid. So we gave this patient some lactated ringer solution when he first came into us, just really to assess his response to intravenous fluid. So we just use an isotonic crystalloid, like lactated ringer solution, the rate being about 10 mils per kilo over 10 minutes. And I'm just going to give this to this patient because I know this patient has sepsis. I don't want to give him too much fluid. So I'm going to give this dog perhaps 2 or 3 boluses of lactated ringer solution over about 20 to 30 minutes. Am I going to give colloids? Well, this dog has enough evidence of critical illness and sepsis going on. So colloids, we know, are relatively contraindicated in patients with sepsis for a number of reasons, but in the larger studies that have been carried out in people, they're associated with in people with septic shock, they are associated with a higher incidence of acute kidney injury. And we suspect that that's the same in dogs and possibly cats as well. So should we give more fluids? Okay, how do we know if we should give more fluids than this 10 mils per kilo over 10 minutes, maybe 2 or 3 boluses of this? Well, can we use things like blood pressure or urine output to determine whether or not we give any more fluids? Can we use central venous pressure, or can we use blood lactate? Well, let's just talk about these things for a minute, because blood pressure is a really important one to monitor in our patients once we're giving them intravenous fluid. Let's say I have a hypotensive patient that is in hypovolemic shock, and I give them IV fluids. If they have a relatively straightforward or non-septic shock, then I would expect to see, after I replace intravascular volume, that my blood pressure would increase. However, if I've got severe systemic inflammation or sepsis, I may not see a change in blood pressure at all in response to my intravenous fluids. And that's a concern, because if I continue to give intravenous fluids just to see if my blood pressure will increase, in the face of a disease like sepsis or severe systemic inflammation, so SIRS or sepsis in my patient, and I don't see an improvement in blood pressure in those conditions, I can end up giving far too much fluid to my patients. So that's the reason why we're going to just give our patient maybe 2 or 3 boluses of shock rates of fluids, and then we stop. We monitor our blood pressure. If there's been no response in your blood pressure after 2 or 3 boluses of IV fluids at shock rates, as we've listed above here, then you should stop giving shock rates of IV fluids, because they're not of any benefit to your patient. In fact, the excess amount of fluid that you give your patients at shock rates beyond the first sort of 20 or 30 minutes or so could in fact increase the likelihood of organ damage down the track. And there's evidence for this in precipitating acute kidney injury. We can get increased third space losses of fluids into the interstitial spaces. We know that that decreases tissue oxygen delivery to every organ in the body, like our brain, our heart, muscles, liver, intestines, and so on. What about urine output? Well, this is another one that if you have a patient that is non-septic, so it does not have systemic inflammation, so a dog that has just been hit by a car, or a cat that's perhaps just been attacked by a dog or something of that nature, or an acute hemorrhagic enteritis, and these patients are oftentimes suffering from acute, relative, or actual hypovolemia. If you give them IV fluid boluses, you will restore blood flow to the kidneys and you will get an increase in urine output. However, in a patient with severe systemic illness, we have a predominance of vasodilators in our body. Cytokines such as nitric oxide, for example, cause widespread tissue vasodilatation in our patients, and other cytokines as well can increase capillary permeability. And so we may not, if we're not getting an increase in blood pressure from our patients, shock rates of IV fluids, we are probably not going to get an increase in urine output. So urine output is great if it increases, but if it doesn't increase, really it doesn't tell us a whole lot, except for the fact that perhaps our patient maybe is excessively vasodilated. And if you can couple that knowledge with measurement of blood pressure, then you probably have your answer. What about central venous pressure? Is anybody here measuring central venous pressure in their practices? Just type in a simple yes or no. And while you're typing that in, I'm going to answer Jose's question. Thank you very much for asking this. This says, what is the real risk of fluid boluses in patients with pulmonary B-lines or edema? Should we be really worried or just monitor? That's a great question, because in this particular patient, we have evidence of aspiration pneumonia. So we know that there is fluid and inflammatory exudate within our pulmonary parenchyma. What's the effect of me giving fluid boluses, perhaps 2 or 3 boluses of shock rates of IV fluids? The reality is it probably doesn't make a lot of difference to the amount of fluid within my patient's lungs, but if I carried on giving my patients IV fluids at shock rates for an hour or an hour and a half, or if I put my patient on 2 or 3 times maintenance rates after I treat my patient for shock, then I could end up with a lot of extra intrapulmonary fluid. So I think in the acute stages of treating shock, the risk is reasonably small because the total volume will be reasonably small over about 20 or 30 minutes. But then we need to think about backing off on our IV fluids to maintenance rates only for most of these patients to avoid the potential complication of just excess pulmonary fluid and pulmonary edema. So I see lots of no's for central venous pressure, and it used to be that we measured central venous pressure quite a bit in our critically unwell patients. And the thought was that we put a catheter that sits just outside the right atrium, and we measure the amount of pressure at right atrial contraction, the amount of pressure that is sent back through our catheter in the jugular vein, and that would give us some idea as to the relative vascular fullness of our patients. The reason this was helpful is that we thought, well, if our central venous pressure is low, then we need to give more IV fluids. And if it's high, then we don't give any more IV fluids. What we now know for several years now is that the accuracy of central venous pressure in determining the vascular fullness, so how much fluid is sitting within our intravascular space, is around about 50%. So we really don't know what central venous pressure is telling us, whether it may be accurate in some patients, or it may be completely the opposite to what we think is going on. So it doesn't really have a lot of value. Now, is central venous pressure the same as invasive blood pressure? No, it's not. I mean, it is invasive. But what you're doing is you're really assessing the amount of pressure in the venous circulation just near the heart. So once all the blood in the body has been returned to the heart, the idea is that you are measuring the pressure in the jugular vein just before it enters the right atrium. So that's really, I guess, or cranial vena cava, just before it enters the right atrium. Invasive blood pressure can also be in the systolic vasculature as well. So you can insert a catheter into an artery and connect that to a pressure manometer and gain invasive arterial blood pressure monitoring. So you can get invasive venous blood pressure monitoring, which is central venous pressure, and venous arterial blood pressure too. Just before we move on, I'm just going to answer Christine's question. She's struggling to differentiate definitions of sepsis and CIRS. As far as I can tell, it's the same syndrome and the patient accepts sepsis is caused by an infection or has an infectious complication, and CIRS is non-infectious. Is that correct? Absolutely, it's correct. So sepsis is really severe systemic inflammation that is complicated by infection. Okay, so it's severe systemic inflammation will cause release of the same cytokines that you get released in sepsis. It's just that a patient in sepsis has an infectious complication. That doesn't mean that sepsis is caused by infection. It just means you've got systemic inflammation that's complicated by infection. So you could have a completely non-infectious inflammatory disease such as pancreatitis, and that patient could get a urinary tract infection and get urosepsis as a result of that, and then have sepsis as a result of that infection. So hopefully that helps to clarify. That's a great question. Can we use blood lactate to determine whether or not we give more fluids to our patient? Well, in the acute patient, acute illness, acute hypovolemia, blood lactate can be very helpful. In fact, blood lactate in a patient with a gastric dilatation volvular syndrome should drop quite dramatically within the first half an hour to an hour of intravenous fluid therapy when it's coupled with simultaneous gastric decompression and so on. However, in a patient with sepsis, blood lactate falls a lot more slowly, and I'll talk about that in a second too. So we give our patient this IV fluid bolus, and if it does or it doesn't respond, regardless, we're going to decrease our fluid rates to maintenance rates only, and we're just going to use lactated ringer solution, and we may supplement our patient at this point with electrolytes that we measure that are low, be it potassium, calcium, and so on. What else should we do for this patient? This patient has documented evidence of aspiration pneumonia, so we begin antibiotic therapy. And the antibiotic therapy I typically begin in these patients is just a beta-lactam antibiotic, usually something like amoxicillin, for example, or you could use potentiated amoxicillin to begin with in this patient until you gain a culture and sensitivity of the discharge that this patient has. Then supportive care really involves analgesic therapy. For this patient, it's about suctioning airways, and in this patient as well, because it's got pneumonia, we want to apply some ventilation therapy. So that's pretty much what we did for this patient. So after 2 hours of treatment of oxygen ventilation, we gave shock rates of fluid, then we dropped them down to maintenance, provided the supportive care. This patient's blood lactate was 7.2 millimoles per liter. Let's just go back a couple of slides and we'll see what his lactate was at the beginning of this, because I've forgotten. Here we go. What should we do for this patient? We have a blood lactate of 8.9 millimoles per liter. So our blood lactate's dropped down to 7.2. Who thinks 7.2 is great and you're really happy with that? And who thinks that the patient's going to die because its blood lactate level after 2 hours is still 7.2? It's not down below that 6 millimoles per liter that some people use. It hasn't dropped down to the normal range. So just really interested in what your thoughts are with regards to that blood lactate concentration. I will tell you that if I had a patient that had a gastric dilatation volvular syndrome with a blood lactate of 8.9, and I treated it for 2 hours and its blood lactate is still 7.2 millimoles per liter 2 hours ago, I'm going to be worried. When I'm in surgery, I'm probably expecting to be more likely to see gastric necrosis. There may be a chance that this patient may be in a category of patients that may be less likely to survive. So I might give my owners a slightly worse prognosis. However, this is a patient in sepsis. And what we know about blood lactate in sepsis is that decreases much more slowly than it does in a patient with acute illness, like acute gastric dilatation volvulus or acute HGE or an acute hit by car patient or an acute dog attack victim. And so what we're really looking for is a decrease in blood lactate of more than about 10 to 20% in the first 4 hours, because that places our patient in a slightly better prognostic group. So this patient's blood lactate has improved by quite a lot, 8.9 down to 7.2 within a couple of hours. So when I'm talking to the owner, I'm saying, well, this in sepsis patients actually puts our patient in a group that is more likely to survive than if it had increased, if it had decreased less. And I love the comment there that this level is better, but it's still not that great. Okay, so and I love also the comment that says it scared me, but the smiley face on the screen suggests the trend is okay. And you're absolutely right. As Madeline's pointed out, the trend is much more important than the numbers that we have. Pulse oximetry in this patient was 90%. Okay, so this is with the dog on a ventilator. Okay, we have our pulse oximeter at 90%. We have urine output of less than 0.5 mils per kilo per hour. Systolic arterial pressure, that's okay. 90 millimeters of mercury via direct invasive arterial blood pressure monitoring through an arterial catheter. We had 90 millimeters of mercury systolic arterial blood pressure. It's not terrific. I'd like it better if it was 100 or 120 millimeters of mercury, but at 90 millimeters of mercury, I'm probably going to get reasonable renal perfusion, even though my urine output's not that great. So what should we do? Just remember that excessive fluid administration following acute volume resuscitation increases interstitial fluid accumulation. We know we're worried about our lungs, but we're also worried about other organs like our gut and our kidney. We know that it can damage that lovely fine membrane that coats the surface of our vascular endothelial cells called glycocalyx. And excess fluid administration worsens outcome following initial bolus resuscitation. So this means that I'm thinking about these things, and I really want to probably avoid giving more boluses of IV fluids. Okay, I know that my fluids have raised my blood pressure to 90 millimeters of mercury. What should I do now if I'm going to give more fluids? Well, I could give it a positive inotrope to help my heart function a little better, or I could consider giving a vasopressor to raise blood pressure, or I could give corticosteroids. What sort of order am I going to give these things? And just before I answer this question, Jalal has asked the question, just to clarify, after we've done our 2 to 3 boluses of 10 mils per kilo per hour, are we just decreasing our fluids to maintenance, like 3 mils per kilo per hour? If I have a patient in sepsis who is not responsive to IV fluids or has a relatively modest response to intravenous fluids, so your blood pressure increases but not really into the normal range, then I'm not going to give more boluses of fluids. I'm going to decrease my fluid rates to maintenance rates. It doesn't mean that when my patient subsequently develops vomiting or diarrhea that I'm not going to replace losses or replace hydration. But initially, I'm going to drop their fluid rates down to maintenance rates. I'll then replace hydration and ongoing losses. But maintenance is where you want your base fluid rate to be. There's increasing evidence to suggest that your patient outcome decreases quite significantly if you maintain patients on two or three times their maintenance rates. Christine's asked the question, if you are reperfusing tissue, would there initially be a rise in lactate entering the bloodstream before you expect it to be effectively metabolized by the liver? It's a really interesting prospect. And in fact, the subject of blood lactate is something we'll be talking about in the critical care course as well, because it's reasonably complicated. But not all blood lactate is generated by anaerobic metabolism. Some of it is, but a lot of blood lactate is now currently thought to be produced by excessive rates of glycolysis and the excessive production of pyruvate, which then gets shunted to form lactate. Now, why would you get increased rates of glycolysis when you have excessive sympathetic nervous system stimulation and noradrenaline release? So the more severe your illness is, the higher your metabolic rate is, the more pyruvate you produce. The rate-limiting step is pyruvate conversion to acetyl-CoA and into the TCA cycle within the mitochondria. And so if we have massive increases in the rates of glycolysis, we get a buildup of pyruvate in the cells, and then that needs to be shunted to form lactate. So yes, it's possible if you have anaerobic or poor tissue perfusion as a cause for some of your increase in lactate, that you might get a transient increase in lactate concentration from that hypoperfusion. It is more likely in sepsis that this is due to a noradrenaline release, and the severity of the illness is the thing that is driving the increase in lactate concentration. And that is the reason why we see this much more gradual fall. So when we're talking about maintenance IV fluids, there's just been a couple of comments on maintenance rates of IV fluids. I can actually send out with the recording a chart that it uses maintenance rates of IV fluids based on the basal metabolic rate of a patient, which is the formula that I use there, just for any clarification. So in this particular patient, what we had was systolic arterial blood pressure that was sitting at 90 millimeters of mercury, but we had poor urine output. So our thought was that in severe inflammation, there are a number of inflammatory mediators called cytokines that cause negative inotropy. They decrease the force of myocardial contraction. So we put this patient on dobutamine, which is a positive inotrope. It doesn't have much effect on peripheral vasoconstriction at all, but it increases the force of cardiac contraction. And so we just put this dog on a middle-of-the-road dose, 7 micrograms per kilo per minute. As urine output increased to 1.2 mils per kilo per hour over 2 hours, the blood lactate decreased to 6.5 millimoles per liter over the following 2 hours. And so we just maintained them on dobutamine, which was great. We thought we were having a great time with this dog. However, at 8 hours after admission, this dog's blood pressure fell to 72 millimeters of mercury. His mean arterial pressure was 58. His heart rate was 190. He had weak pulses. His blood lactate started to go back up again, and he had no response to one bolus of IV fluids. We said, oh, maybe he's become hypovolemic. We gave him a single bolus of fluids over 10 minutes to see if there was a response. There wasn't, so we gave him another one. We probably didn't need to give him the second one, okay? So there was no response at all to IV fluids. So now what do we do? What are we going to do? Well, what we did, we could put him, or what we could do is put him on an infusion of a vasopressor, either dopamine or noradrenaline. Now, the literature suggests that noradrenaline is a better choice for dogs. A little bit less is known about cats, but certainly for dogs, outcomes are found to be better, certainly in human medicine. We suspect the same in dogs as well, with less side effects. So noradrenaline, but if noradrenaline is quite expensive. So if you've only got dopamine in your practice, use that at the lowest effective dose. Lowest effective dose in order to achieve an improvement in blood pressure. Bear in mind that both of these drugs, because they're vasopressors, they will cause vasoconstriction in your kidneys, the gut, the liver, and the skin. So the same places that adrenaline causes vasoconstriction. So we don't want to use really high doses straight away. We start off low dose and we increase our dose so we get optimum effect. So after 30 minutes of dopamine at 8 micrograms per kilo per minute, we had a systolic arterial pressure of 74 and a mean arterial pressure of 55. So we increased his dopamine dose to 12 to 15 micrograms per kilo per minute over the following half an hour or so, and there was no change at all in either systolic or mean arterial blood pressure. That's where we're going to leave our case right now, because I want to have a chat about what we're talking about tonight, which is critical illness-related corticosteroid insufficiency. Now, in the normal patient, this is going to circle back now to some relatively dull pathophysiology and pathology and physiology about what happens to cortisol in normal patients. But we can see from this diagram here that we have corticotrophic releasing hormone, ACTH as well, that are released in response to dropping serum cortisol levels, and they stimulate the adrenal cortex to produce cortisol, which subsequently decreases the release of CRH as well as ACTH as well. The effects of cortisol in the bloodstream and in the tissues are to increase rates of gluconeogenesis, so new glucose formation, protein catabolism, fat catabolism as well, and to stabilize lysosomes. So there is actually specific mechanisms by which we'll run into in a couple of seconds time, whereby cortisol decreases the rate of activation of some enzymes within lysosomal organelles. So when we think of cortisol, there are several actions. There are genomic effects, which basically involve really complex gene expression within a cell. So there are cortisol cell receptor complexes, and they alter gene expressions associated with metabolism, so the gluconeogenesis and inflammation and so on. But there are also non-genomic effects as well. So cortisol will bind to glucocorticoid receptors on our vascular endothelial cells to inhibit nitric oxide production. Now, you might have gathered from what I said before that nitric oxide is a really potent vasodilator. So this non-genomic effect of glucocorticoids, it can just bind to glucocorticoid receptors on vascular endothelial cells and can inhibit or reduce the rate of production of nitric oxide. So keep that in the back of your mind, because that's one of the key things that we need to think about when we consider giving corticosteroids to patients with severe systemic illness. They can also bind to transcellular kinase pathway. Okay, so this is what I was talking about in the lysosomes. Lysosomes are little organelles that sit within our cells, and they are loaded with enzymes, one of which is a phospholipase, or a group of enzymes called phospholipases. Phospholipases digest fats within cells, and our cell membranes are made up of a phospholipid bilayer. So these phospholipases cause massive cell damage when they get activated. So corticosteroids within the cells actually inhibit production of phospholipases. They also impair T lymphocyte cell signaling as well, and so they can dampen the inflammatory response a little bit. So that's what happens in normal patients. Okay, we have this relatively simple, what's called a negative feedback loop, where high levels of cortisol inhibit the release of CRH and ACTH from our brain to decrease cortisol production within the adrenal gland. When cortisol levels fall, we get an increase in release of ACTH and CRH from our brain, and that increases cortisol production. Well, in critical illness, noradrenaline, because it's a stress hormone, will cause an increase in both CRH and ACTH secretion in the brain, just the same as when we're stressed, we get an increase in cortisol concentration. We also get release when we are in shock and in critical illness of vasopressin. And vasopressin gets released from the hypothalamus, and this increases ACTH, or adrenocorticotropic hormone. This is the hormone that tells the adrenal gland to make more cortisol. So we can see there's two big stimuli for cortisol secretion. We also have inflammatory mediators that act independently of our brain to just directly stimulate the adrenal cortex to produce cortisol. But there are other inflammatory mediators that stimulate our autonomic nervous system that also stimulates cortisol releasing hormone as well. So we have three mechanisms by which our patient in critical illness will directly stimulate our brain to tell our adrenal glands to make more cortisol. And then we have another mechanism by which inflammatory mediators will directly stimulate the adrenal gland to produce cortisol, all of which tells me that a patient in critical illness should have a high baseline serum cortisol concentration. So why would we run into this problem where we have critical illness-related corticosteroid insufficiency? Well, let's investigate this a little bit more. Because cortisol metabolism in critical illness is actually reduced. Now you're thinking, Philip, if the cortisol metabolism is reduced, then surely serum cortisol concentrations are going to be high. Well, yes and no. The result is that if we have decreased cortisol metabolism and increased cortisol production, we should expect to see really, really high cortisol concentrations in bloodstream. But the result of what we actually see in our patients is that we have either normal or only mildly increased ACTH or CRH concentrations. We actually end up with normal or mildly increased cortisol production, but we get dramatically increased cortisol concentrations. This is important when it comes to testing our patient for whether or not they have critical illness-related corticosteroid insufficiency or not. So up till now, what we have is lots of stimulation to produce cortisol. We have massively increased cortisol concentrations, but our ACTH and cortisol production levels are actually not that high. That's what we should expect. So why is cortisol secretion, though, if we've got all the stimulus to secrete cortisol, why is cortisol secretion only normal or only marginally increased in critical illness? Well, it's because of a whole lot of other things. There can be hemorrhage from conditions like disseminated intravascular coagulopathy due to severe systemic inflammation in our patient. We can have elevated adrenal blood pressure, and we can have ischemia as well. This particular photograph was taken from a patient that had a kidney avulsion secondary to a dog attack. It's also got some diaphragmatic tears that we can see in here as well. But this is a patient who had lots of hemorrhage around his adrenal gland as a result. We can also have interleukin-1, which is an inflammatory mediator or a cytokine that stimulates an initial increase in cortisol secretion, but then it modulates that through an increase in nitric oxide synthase in the hypothalamus, and nitric oxide causes apoptosis or death of the neurons in the hypothalamus and the pituitary that blunts the cortisol response. I see a couple of questions here that would blood cortisol be significantly increased versus a stressed animal in a clinic? Would measuring base cortisol be useful at all? We're going to get to that. I think that's a lovely question. It's really good. All right. That's the third reason why we only get a marginal increase in cortisol production, is that the more cortisol there is in the bloodstream, the more negative feedback we're going to get in our brain as well. And we also can get reduced adrenal production from a cholesterol substrate shortage in patients with acute illness and really high metabolic rates and decreased caloric intake and so on. We can get reduced cortisol secretion secondary to medications like etomidate or benzodiazepines and opioids. And a lot of our critically unwell patients will be on opioid continuous infusions and also benzodiazepines as well. And we can also get an increase in cortisol, in tissue resistance to cortisol, and a reduced cortisol breakdown. So to sum up with the pathophysiology, there's a lot that is known, but there is a little bit that is unknown. There are basically multiple mechanisms that are suggested. We get inadequate production of cortisol plus or minus that CRH and ACTH, and we get an altered tissue sensitivity to cortisol. We call this peripheral tissue cortisol resistance. Critical illness-related corticosteroid insufficiency is known in both dogs and cats, which is why we're talking about it now. There's a lot more that's known about it in humans, but I'm going to review what we do know about it in dogs and cats and how we diagnose it in a second. In fact, right now, let's talk about diagnosis of critical illness-related corticosteroid insufficiency. Just before we do, Jose's asked a question, should we always follow the sequence to manage hypotension in these critical patients? Fluids, vasopressors, and then maybe glucocorticoids. I would add in there perhaps fluids then plus or minus positive inotropes like dobutamine, then vasopressors, then glucocorticoids, if we're going to follow down that track. Glucocorticoids is usually the last thing that we might consider to use. It's another question just on the role of cortisol and canine parvovirus viral enteritis. There's no evidence that it's of value in those patients unless they fit the criteria of being in septic shock, as we'll talk about later on in this session. Good questions. All right. In people, 30 to 45% of patients with sepsis and hypotension have got critical illness-related corticosteroid insufficiency. How do we know how to diagnose it? So diagnosis is critical. We see from the somewhat interesting and somewhat confusing physiology of cortisol in the critically ill patient that it has a number of mechanisms by which the cortisol level might be increased, but what we see in the actual patient is maybe mild to moderate increased rates of production by our adrenal glands, and maybe in some patients quite high levels of cortisol, but an apparent decrease in the ability of the body to be able to respond to cortisol. So the diagnosis of this condition is really critical. We don't want to miss nearly half the patients in our hospital that may benefit from glucocorticoids. So let's talk about baseline tests, cortisol, ACTH, and ACTH stimulation. The cortisol assay, some studies show that higher baseline cortisol concentrations are associated with higher mortality. And then other studies show poor predictive value. So the value of taking a baseline cortisol is currently a little bit ambiguous. So we're not quite sure whether or not it's a useful test or not. I would say that if you had higher cortisol concentrations, you might be inclined to think, well, maybe my patient has more severe illness because there's much greater stimulus to produce cortisol from its adrenal gland. Does that mean that patient has critical illness-related corticosteroid insufficiency? We don't know enough about baseline cortisol assays to say that right now. And the studies that came out after the initial study that showed a higher cortisol was associated with high mortality showed pretty poor predictive value based on baseline cortisol concentrations. So what about ACTH stimulation test? Well, there are a few studies carried out in dogs. Study 1 I've listed here, it's 48 dogs. They found that the change in cortisol concentration of less than 83 nanomoles per liter were more likely to need vasopressor therapy. So this tells us when we perform an ACTH stimulation test, if our patients don't produce significant amounts of cortisol in response to being given exogenous ACTH, where we give the ACTH to our patient in the ACTH stimulation test, then they're more likely to need vasopressor therapy. So that sounded like it was a great study. It seemed to give a nice, clear result. Study 2 looked at 33 septic dogs, and they found that the change in cortisol concentration of less than 80 nanomoles per liter, so around about the same level, were more likely to have hypotension and were 4.1 times more likely to die. So the combination of these two studies suggests maybe we should do an ACTH stimulation test to try to detect whether or not a patient might need some additional cortisol. Study 3 looked at 21 dogs with systemic inflammatory response syndrome. They found hypotension and elevated baseline cortisol predicted survival, but that the change in cortisol following an ACTH was not predictive of survival. So this is a study which sort of says, well, ACTH stimulation test may not be as good as the previous two studies might suggest. You love animals. They really, and biology and medicine, full stop, because we are dealing with biological entities and very complex pathways. And so when two studies come out and say ACTH stimulation test is great, and then one study comes out and says, well, it actually didn't predict survival in our study. Those are the only canine studies we have, by the way, for diagnosing CIRCI with ACTH stimulation test. In humans, they've done this a lot more, and there is similar uncertainty where some tests looking at baseline cortisol suggest it's beneficial in predicting outcome. Others are not supportive. ACTH stimulation test in some studies suggests that it's useful, and in other studies it suggests it's not useful. So what do they use in people? The criteria that they use are that the patient has to be in sepsis, and they have to have been given intravenous fluid therapy and vasopressors that have failed to increase blood pressure. And the third part of the diagnostic criteria is that we give a response, a low dose of corticosteroids, and we assess the patient's response to that low dose corticosteroid. So essentially we have a list of pre-existing criteria. We've got a patient in sepsis. They've had IV fluids, they've had vasopressors, and our blood pressure is still low. We give them a low dose corticosteroid and their blood pressure improves. We have a diagnosis. If we give corticosteroids and their blood pressure doesn't improve, they don't have critical illness-related corticosteroid insufficiency. So that's the current human criteria for diagnosing critical illness-related corticosteroid insufficiency. So refractory hypotension, despite volume loading and vasopressor therapy, is what we currently use as a diagnostic criteria for diagnosing critical illness-related corticosteroid insufficiency. What are the first-line vasopressors that we recommend? The vasopressors we mentioned before. Noradrenaline is probably my first choice. Dobutamine would be my second choice if I didn't have noradrenaline, or if I had, if the cost of noradrenaline was going to make my clients cry, then I might use dopamine. But noradrenaline is associated with slightly better outcomes, at least in human medicine and critical ill patients. So that's the one we tend to use. There are a number of pharmacological effects of dopamine that are undesirable that we could go into in another webinar, but microcirculation is altered quite significantly with dopamine infusions, and it can result in decreasing perfusion to many tissues as well. So, I think noradrenaline is usually where we go first, but if you only have dopamine, then that's the one I would use. So, due to disparate data from different studies, the human critical care community does not advocate any method of diagnosis for critical illness-related corticosteroid insufficiency at present. That came from an article in 2015. Nothing has changed to date. So in a practical sense, the diagnosis of CIRCI in people is currently made by evaluating the response to treatment once those important pre-diagnosis criteria are met. So how do we go about treating critical illness-related corticosteroid insufficiency? Well, unsurprisingly, we give our patients corticosteroids. The dose in people is the equivalent prednisolone dose of 1 milligram per kilo. There's a lack of published evidence in dogs and cats. We are currently using doses of, that should be 0.5 to 1 milligram per kilo, not /5. So 0.5 to 1 milligram per kilo is what we're currently using of hydrocortisone in dogs and cats. What's that dose again? Well, the studies that we have, the 4 studies that we have in dogs and cats, we've got a couple of choices, 1 to 4 milligram per kilo per day, divided into 4 doses given every 6 hours. So basically, we're going to give like 0.8 of a milligram per kilo per day, 0.8 of a milligram per kilo every 6 hours or something of that nature. Okay, that's hydrocortisone. Or we can give 1.4 milligram per kilo per day given as a continuous infusion. That's 0.04 to 0.16 milligram per kilo per hour. Or we give 0.5 milligram per kilo IV every 4 hours, or we give 0.08 to 1.2 milligram per kilo per hour continuous infusion. So similar, lower dose at least to this, the one up here, but actually quite significantly higher dose. 1.2 milligram per kilo per hour is very, very high. This was used in the 4th study in a cat. How long do we need to treat for? Well, there's no clear protocol for that either. Treatment, however, based on extrapolation from human medicine, may be needed for up to 3 to 4 days at the initial dose. So this is these doses here that we're talking about. And, if we stuck with roughly, this continuous infusion rate of 1 to 4 milligrams per kilo per day as our total dose for around 3 to 4 days. And then what we do is we just reduce the dose by either 25% per day or 50% every 48 hours after that initial 3 to 4 day period. So our patient will probably be on this hydrocortisone for a period of perhaps 3 to 4 days plus 3 to 4 days. So 6 to 8 days it's going to be on this corticosteroid treatment if it shows a response. Can we use dexamethasone? You can use dexamethasone, although it is reported to cause a higher incidence of gastrointestinal side effects, and hydrocortisone or prednisolone equivalent would be better than dexamethasone just because of that. So you could use prednisolone, you could use methylprednisolone, sodium succinate as well, or you can just use hydrocortisone. We've just listed hydrocortisone there, but you could use methylprednisolone, sodium succinate, or equivalent prednisolone dose. What about cats? What do we know about cats? Because all of those studies were from dogs. There were a couple of articles I could find on cats. One looked at 20 cats. They were all critically ill cats, had higher cortisol concentrations, but there was no difference in baseline cortisol, the change in cortisol or ACTH stimulation response between survivors and non-survivors in critically ill cats. And because cats are so unique, I don't think there's any surprise there, because cats would read a textbook and then just do something different because they're cats. But this is one of the evidence that we have in cats, that it didn't appear in these 20 critically ill cats. There was no difference in baseline cortisol or the change in cortisol secondary to ACTH stimulation between survivors and non-survivors in critically ill cats. Second study with 19 cats with sepsis, the change in cortisol concentration was lower in sepsis than in normal controls. There was no difference in the change in delta cortisol between survivors and non-survivors. So certainly septic cats had a lower change in cortisol than normal cats, but among all cats that were sick, there was no difference in the change in cortisol between survivors and non-survivors. So baseline cortisol and ACTH stimulation test, similar sort of situation to what we have in dogs. The third study was actually a case report. It's the only specific case report. This was a cat that had septic peritonitis secondary to a ruptured pyometra. It had vasopressor resistant hypotension and responded very well to hydrocortisone. Okay, so this was given at quite a high dose. This was back at the 1.2 milligrams per kilo per hour dose that they had. I think it was that dose. Let me just go back a couple of slides there. The 1.2 milligram per kilo per hour there. Hydrocortisone treatment in a cat with vasopressor refractory septic shock and suspected critical illness, corticosteroid insufficiency. So this cat had quite high doses, quite a high dose rather of hydrocortisone, but responded very, very well. There was another case report published back in 2007 looking at a polytrauma patient that had vasopressor-resistant hypotension and that had clinical improvement with glucocorticoids. They actually used dexamethasone in this particular patient, and in the review or the discussion they did speak about the less desirable effects of dexamethasone over hydrocortisone or methylprednisolone or prednisolone. So if you have a preference, or if you have in your clinic the ability to give prednisolone, methylprednisolone or hydrocortisone, I would be using those. What is the prognosis for this condition? In patients that survive their critical illness, the return of normal hypothalamic pituitary and adrenal axis function is actually really very, very good. They have to survive their underlying disease. Okay, so that's the big thing that will kill the patient, but this is just an inconvenient complication that you may come across in some septic patients. So what I thought we'd do is just finish off with a short case, a little bit shorter than the previous one. This is an 8-year-old female spayed dog with chronic staph, pseudo-intermediate skin infections. She'd had chronic management with prednisolone and occasional episodes of antibiotic therapy. Acute onset of respiratory distress was noted. Ataxia and collapse followed a 36-hour history of slightly reduced appetite and lethargy. So this patient came into us not in a good way, it's fair to say. On presentation, the dog had a heart rate of 220 beats per minute with a weak pulse, a systolic arterial blood pressure of 100 millimeters of mercury, but not having fun breathing. Pulse ox of 84, lung ultrasound rockets all over the lung fields, pyrexia, temperature 40.9 degrees. We gave her initial fluid therapy, again 10 mils per kilo over 10 minutes, repeated 3 times in 30 minutes, and we actually reduced this dog's rate down to 1.5 times maintenance. This was really to help with rehydration in this particular dog. We ventilated the dog and monitored blood pressure, urine output, and attached everything else to the patient as well. So over the next 4 hours, our blood pressure, systolic arterial blood pressure, which was not too bad at 100 millimeters of mercury, that dropped to 60 millimeters of mercury. Urine output fell to less than half a mil per kilo per hour. Blood gas was stable. It wasn't terrific. Blood lactate was stable. Heart rate was 160. Pulse oximeter 95. So what should we do next? What do we want to do next for this patient? Please just feel free to type your answers in the chat box there. Very interesting question. With this critical illness-related corticosteroid insufficiency diagnosis and subsequent treatment of it with corticosteroids, would that treatment be contraindicated if the patient's already been on non-steroidal anti-inflammatory drugs? What's going to kill my patient first is sometimes what I would be thinking about. And if my patient's already been on non-steroidal anti-inflammatory drugs, yes, I have a real risk of acute kidney injury in my patient if I'm subsequently giving corticosteroids. But I'm giving quite low doses. These are physiological doses of corticosteroids. And my patient without these corticosteroids could die from refractory hypotension. So I'm probably going to advise the client that there is a risk down the track of acute kidney injury from this intervention, but without it, my persistently hypotensive, non-responsive patient is going to die of acute kidney injury anyway, so I need to do something for them. So I guess that's one of those judgments that we need to make. Positive inotropes and vasopressors is what we've got coming as far as our suggestion is. And look, I think, could we give a bolus of IV fluid? Well, we could, but we've already given 3 before. We began in this cat dopamine when we didn't see any response to a fluid bolus, and we just began 5 micrograms per kilo per minute and increased it to 15 micrograms per kilo per minute over 3 hours. Now, I could have given dobutamine to my patient to increase cardiac output. My blood lactate was pretty stable here. Urine output certainly fallen. I've got a significant decrease in blood pressure. And what you'll notice is that in the previous patient, we had kind of normal blood pressure. It was sitting at 90, but I just had poor urine output. This patient, my systolic arterial pressure has fallen to 60. I need to constrict my blood vessels. And that's the reason why we chose dopamine in the first instance in this particular patient. So we managed to get a bit of a response to urine output. It increased to 2.1 mils per kilo per hour for 4 hours, and it pretty much stopped. It fell precipitously. Systolic arterial pressure increased to 80 millimeters of mercury initially, but fell below that, necessitating an increase in dopamine dose. She became refractory to those increasing dopamine doses, so we started her on dobutamine. The urine output improved a little bit. The blood pressure was still really low at 60 to 80 millimeters of mercury. So you see, we ended up putting this dog on dobutamine anyway. So in some ways, it may not matter too much which one of those you start in these sorts of patients. I was more concerned about that really low blood pressure. So I wanted to increase the blood pressure first, which is why we used the vasopressor. But when things were not looking all that great, we thought, well, let's put this dog on dobutamine. We know that she's in sepsis. She will have reduced myocardial contractility, and interestingly there is you can actually measure cardiac output with an ultrasound if you get good at it, and we'll talk about that at one of our sessions in our online vet conference later on this year that Vet Education is holding in July. So what next? If we've done all of this and our blood pressure systolic is 60 to 80 millimeters of mercury, sort of hovering around 65, then it'll be 72, then it'll be 63. We didn't really get any consistently nice results out of our blood pressure monitor. So what do we do next? Do we give noradrenaline? Do we give vasopressin? Or do we give corticosteroids? What shall we do for our patient? We have criteria here for critical illness-related corticosteroid insufficiency in this patient. And this is the patient that I would be giving corticosteroids to. Okay, it's because we have used intravenous fluid therapy, we have appropriately used vasopressors, and we have significant vasodilatation and a failure to improve. We could use vasopressin, but it's really just another vasopressor, and we've already given our patient dopamine in order to try to increase. So low-dose corticosteroid to see if the blood pressure increases at all. And so that's the approach that I would use for these particular patients. So hydrocortisone 1 milligram per kilo IV, and then 0.1 milligram per kilo per hour for up to 2 to 3 days afterwards. And that's the plan of action that you'll have for your patient. So with this particular patient, systolic arterial blood pressure improved within 30 minutes, up to about 100 millimeters of mercury and 68 millimeters of mercury respectively, and remained pretty stable. However, the dog remained anuric and had severe respiratory distress syndrome, and the owners actually elected to euthanize this dog at postmortem and had severe Staphylococcus septicemia as a result of its chronic skin infection. So a sad outcome for this patient, but an illustration of the sort of response that you are going to see. Most of it appears to be modulated by the decrease in nitric oxide production at that endothelial cell membrane due to that direct non-genomic effect of corticosteroids. So yeah, look, good question. Do I use an ACTH stimulation test if I suspect a CIRCI patient routinely? The short answer is no, I don't, because the evidence is a little contradictory. If I get a small response to ACTH stimulation, it tells me maybe my adrenal glands are not able to produce enough cortisol. Maybe I have cortisol resistance, but then I'm left waiting for those results for maybe a couple of hours, and probably my patient might need that corticosteroid injection now. Would this dog have had septicemia if it had had more antibiotics for the skin? Oh, that's a good question. So this dog had had intermittent courses of antibiotics and was on chronic corticosteroids, and I'm not sure from memory if this dog, because it was an outpatient from another clinic, so it came to us referral, and I'm not sure if routine antimicrobial sensitivity had been performed, or even if the antibiotics the dog had been on were going to be effective at all. Good question. I thought steroids took at least 4 hours to work because they work by affecting the DNA transcription and translation. Is that outdated? No, that is, if you're looking at an effect of corticosteroids to produce massive vasoconstriction secondary to anaphylaxis or something like that, and or decrease inflammation, yes, they need to use those genomic effects that occur in the cell through DNA transcription and so on, and change in protein production and so on. But the direct non-genomic effects of corticosteroids to reduce nitric oxide production, they occur much more rapidly, and we see responses very, very quickly with regards to that. If the patient's got known heart condition, would you alter the IV fluid bolus protocol and go straight to the positive inotropes and pressors? Yes, if the patient has heart disease. So if it's got dilative cardiomyopathy, for example, or mitral valve disease, then we could cause a lot of problems by giving shock rates of IV fluid. So typically, we might use maybe one bolus of IV fluids if the heart failure is well controlled. If it's not well controlled, we go ahead and we manage the heart disease that this patient has. Now, I'd use an inotrope first. The problem with using vasopressors in these patients is that if you increase blood pressure too much, then you increase afterload. So you increase the force against which the failing heart has to beat. So I like to use positive inotropes in the first instance, and then the lowest possible dose of vasopressor that achieves normal blood pressure for your patients. Great question. Yeah, I didn't think chronic skin conditions could cause septicemia either. That was the first case I had seen of a chronic infective skin condition that had caused septicemia, but that was the post-mortem diagnosis in this particular dog. Once we get resistance to antibiotics, it would be a disaster waiting to happen. Absolutely, Jeanette, I agree. That's a real problem for this patient, because you could put them on antibiotics and you wouldn't be killing the underlying pathogen, and so this disease would quite rapidly take a hold. And I think that's certainly in this particular dog, the suppurating wounds and the pneumonia that was associated with the septicemia was pretty significant. All right, so that is what I had for you this evening. Thank you so much for coming along to this session on critical illness-related corticosteroid insufficiency. The goal of the session was really to highlight that this is a condition that exists in dogs and cats. We diagnose it through having hypotension despite adequate amounts of IV fluid therapy and the use of vasopressors. And we've talked a bit about positive inotropes too in our global management of these septic patients. They must have underlying sepsis or systemic inflammation, and we diagnose it really based on having those pre-criteria and a response to physiological doses of corticosteroid. It's an interesting condition. I have no doubt we will learn more about it in future. This is really just updating us on what we currently know and understand. I want to thank you all for your wonderful, wonderful questions. I'm just going to see if there was any questions that I had missed there. Just bear in mind that this lecture has also been brought to you by our upcoming course for veterinary nurses and technicians. Vets can take it as well. We've got a couple of vets who've already signed up for this course too. It's really helpful, goes through the entire gamut of nursing care, diagnostic tests, and management of the critically unwell patient. It starts on May 31st. It's 4-week. It's race approved for continuing professional development credits as well. It's all done online, and there are weekly live tutorials held in a room very much like this one. And there are practice protocols, checklists, current literature reviews, and other information as well. And there's a whole lot more coming too. So if you're interested, please head to our website, veteducation.com.au, click on courses and vet nurse courses. There's a description of what's going on in there. There's a lot more than what I've been able to write there under the weekly sessions. We normally digress and we cover more topics than are actually listed. I've just seen a great question. If I could pick one pressor or inotrope to have in practice, what would it be? So the one inotrope I would have in practice would be dobutamine. I think it's a really helpful drug. A vasopressor, I think noradrenaline is probably the best. It is expensive, and in my experience, the shelf life of it is reasonably short given the vials that we get. They seem to have only a 6-month expiry, and you may or may not use it in your practice within that time. So it is quite expensive, but that would be the one that I would have. For the less expensive option for a vasopressor, you've got a choice of vasopressin, which is vasopressin, or you've got dopamine as your choices. Thank you so much again, everyone, for coming along tonight. I think I've got one more slide that's just returning to the title slide. It's great to see you all here. I'll stick around for a little bit longer just to type in some answers to any questions that you may have once we put the music back on. But thank you again. What dose do we start with dobutamine? Typically, I'm going to start around about 5 micrograms per kilo per minute for dobutamine, and you can increase it every 5 to 10 minutes if you're not seeing a response. Okay, so I typically wait about 10 to 15 minutes to be quite honest, but it's got a really short half-life and it acts very, very quickly, much the same as dopamine. So you can tweak these doses reasonably over a reasonably short time frame in your patients. Awesome. I'll put the music on now. Thank you again, everyone. I hope you have a wonderful and safe remainder of your evening, and until we meet again, take care and good evening.